Okay, let us start. So today we will be discussing about infections of the urogenital tract. Now, on differentiating the urogenital tract, we can divide into two parts: the urinary tract part and the genital system. So, under urinary tract infections, we will be covering about the infections of the organs with respect to the urinary tract system. So, what are the organs there? It will start from the kidneys, ureter, the bladder and the urethra. Now, we can divide the urinary tract into two parts, the upper urinary tract and the lower urinary tract. The basic differentiation is the bladder. Any infection, bladder and below is called as lower urinary tract, and anything above the bladder we call it as the upper urinary tract infections. So, any infection as you can see in the picture, if the infections are related to the kidneys, we call it as pyelonephritis. Pyelo means the pelvis of the kidney, and nephritis obviously it means infection of the nephrons. Then if the ureters are infected, then we call it as urethritis. Now coming to the lower urinary tract infection, if there is isolated infection of the bladder, we call it as cystitis, or it could be an infection from bladder to urethra, we can call it as lower urinary tract infection, in which inflammation of the urethra we call it as urethritis. Now, one more important differentiation you should know, something called as the CAUTI or catheter associated urinary tract infections. So, this is basically an healthcare associated infection seen in patients who have undergone a procedure called urinary tract catheterization, and that catheter must be placed for a time period of at least 48 hours. We will discuss about CAUTI later on. In today's discussion, we will restrict ourselves only to the upper and the lower urinary tract. Okay. Now, so these are the main differences. Obviously, we have understood which of the organs are affected in upper urinary tract and the lower urinary tract infections. Now, coming to the manifestations. The manifestations will also similarly be different in both the cases. For example, in case of lower urinary tract infections, let us start with the most distal part. If there is inflammation of the urethra, what will be the complaint of the patient? The urine flows through the urethra. If there is inflammation in the mucous membrane of the lining of the urethra, there will be pain during urination, because the urine has a low pH. So, low pH will obviously irritate the urethral mucosa, and the patient will complain of pain or burning sensation during urination. That is the symptom of urethritis. Now, in case of bladder, what would be the symptoms? What is the function of bladder? It holds the urine. If the mucous membrane of the bladder are irritated, it will not be able to hold the urine for a prolonged period of time. So, what the patient will complain? The patient will complain that I have to go to the toilet more frequently. This is called as frequency of urination. Even a small amount of urine in the bladder will give a sense of full bladder because of the irritation of the mucous membrane. Another symptom that may present is because of the irritation, the patient may complain of pain on the urinary bladder. Now, what is the anatomical location of the urinary bladder? It is the pubis symphysis. So, the patient will complain of lower abdominal pain. So, the local manifestation may be dysuria, urgency. Urgency means, any idea what is urgency? Why? See, when we get a sense of filling of the bladder, we can still hold it. That means we can control it. How? Because our parasympathetic system will help the bladder to relax more. But if there is ongoing inflammation, this relaxation will not happen. So, whenever the patient feels that my bladder is full, he or she has to go to the toilet immediately. Cannot hold. So, these are the classical symptoms of dysuria, urgency and frequency. These indicate inflammation of the bladder. Okay. But suppose if the kidneys and the ureters are affected, what would be the manifestation? Now, kidney is a retroperitoneal organ. If there is inflammation in the kidney, the patient will complain of severe low back pain, and that pain can be felt on examination of the abdomen, called as renal angle tenderness. Furthermore, because it's retroperitoneal and is encased, any inflammation will lead to চলে কি পড়াচ্ছে বাহ Now coming to the predisposing factor of the urinary tract infections, obviously you must know that females do have a shorter urethra, hence in case of lower urinary tract infections which are more commonly acquired with the ascending route, the chances of infection are higher in case of females as compared to the males. And now it is very important that you must understand that urinary tract infection, especially the lower urinary tract infections in males, obviously demands thorough investigation, because until and unless there is any kind of anatomical or physiological compromise, the chances of infection in male urinary tract is much lesser. Completely in contrast to the female urinary tract infections, which are more commonly seen because of the shortened urethra, and more obviously the urethra is more prone to get colonized with the organisms of the anus and the in the perianal region. Now furthermore, we can see the incidence increases with the age, especially with the females and with menstruation. Some of the predisposing factors which does predispose include pregnancy, where there is not only pressure from the uterus on the bladder, but also there is relaxation of the bladder with retention of urine, and obviously in pregnancy most of the infections are more commonly. More importantly, we can find infections more commonly seen in case of obstruction or functional abnormality of the urinary tract. It may be a structural abnormality or may be a functional abnormality which can be seen in neurological injury like neurogenic bladder or any kind of spinal injury. So other important causes would include the organisms which cause infections. More commonly, you have I think you have read about Escherichia coli. Some of the variants of the Escherichia coli will have a peeling protein. This peeling protein helps in the addition of the bacteria in the urinary tract. Thereby, it may progress even though against the flow of the urine and may reach the bladder, causing infections. A very notable structural abnormality that can be seen is called as the vesico-uretary reflex. If you have read, vesico-uretary reflex is the laxation of the vesico-ureteric junction, thereby leading to reflux of urine from the bladder into the ureter, thereby helps in ascending of the infections to the kidneys. Now, this is the composite picture of all the organisms which causes infection of the urinary tract. You can see most common cause of the urinary tract infections are obviously bacterial cause, and among the bacterial cause, the most common organisms are the gram-negative bacilli. More commonly, Escherichia coli, Klebsiella, Enterobacter. These are common infections seen not only in community acquired but also in hospital acquired infections, and some of the non-lactose fermenters, which would include the Pseudomonas and Acinetobacter species. Gram-positive organisms generally do not cause infections with the exceptions of Staphylococcus and Enterococcus species. However, tuberculosis infection can be seen at anywhere in the urinary tract, from kidney to the ureter to the bladder. Among the fungal agents, the most common causative agent is Candida, which obviously causes urinary tract infections, and in parasites, I think you have read about schistosomiasis, which is an infection of the bladder. Trichomonas vaginalis is a very common agent of sexually transmitted infection called Trichomonas vaginitis, and also can cause infection in the bladder. Some of the viruses like BK virus and adenovirus can also cause infections. Now finally, look at the organisms, that is the gram-positive cocci. These are the very important bacterial causes. Among them, the Enterococcus. The Enterococcus is a gram-positive cocci, and sometimes it is resistant even to vancomycin. Similarly, Staphylococcus saprophyticus, it's a coagulase negative staphylococci. Generally, this infection is more commonly seen in females, and especially along with Streptococcus agalacti, these can cause serious consequences in pregnancy. Okay. Now, if we look at other infective manifestation other than the upper and the lower urinary tract infection, one more manifestation that can be seen is the immunological sequela. It is called as the post-streptococcal glomerulonephritis, that is immunological deposition of the antigen or the antibodies or antigen-antibody complex on the glomerular membrane can lead to immunological complexes. Now, what would be the outcome of the urinary tract infection? The first outcome is called as asymptomatic bacteriuria. What is asymptomatic bacteriuria? As the name suggests, the patient does not have any symptoms. But if we take the urine sample of the patient and examine it microbiologically, we can find huge number of bacteria present in the urine. Now, there lies the question. So, does it means that the patient is infected? The organism is present, but the patient has no symptoms. Well, normally we do not need to consider it to be serious until unless in specific patient category. For example, in pregnancy, I have already told you because of the physiological state, there is retention of urine and the immune compromised state of during pregnancy, the chances are that asymptomatic bacteria may lead to severe infections. Similarly, suppose you do get a patient who has asymptomatic bacteria, that means no symptoms, but bacteria are present in the urine, and the patient will be undergoing any kind of urological procedure. It could be a prostatectomy or maybe a cystoscopy, any sort of urological procedure. If that is the case scenario, then we need to treat this patient, because if we don't treat this patient, this organism may lead to severe infections. Now, look at the second line. Routine screening and treatment for asymptomatic bacteria is not recommended until and unless these two select category of the patients. Okay. So, in whom it is not significant? In non-pregnant, premenopausal woman, old age, catheterized patient, and patients with spinal injury. Why? Say in non-pregnant, premenopausal, that means in the reproductive age group. In the reproductive age group, because with every menstrual cycle there are changes of the mucosal membrane in the vaginal cervix and even in the vulva, along with there is a change of the organisms which colonize. So in these patients, bacteria will always be present in the urine sample collected normally, that is normal micturated urine. So you don't need to treat these patients. One. Next, old age. Why? Old age colonization is very common in catheterized patient. After putting the catheter in the patient, colonization starts within 2 hours after catheterization. So if you have put the catheter for at least 1 to 2 days, obviously the urine that you are getting will be colonized with bacteria. This does not mean that the patient is infected. And finally, any sort of spinal injury means there is dysregulation of the normal voiding of the urine. If the physiological voiding of urine is affected, colonization will be there. So in this category of the patients, you don't need to screen or treat. So who should be treated? Pregnant woman, any patient undergoing any kind of urogenital surgery where bleeding is expected. Bleeding means obviously if there is bleeding, there is a chance of seepage of the organism into the bloodstream leading to urosepsis. The second kind of manifestation that can be seen is called as cystitis. Cystitis means inflammation of the bladder, where I have already told you the most predominant symptom will be dysuria, frequency and urgency. Now the patient may also even complain of whitish or cloudy colored urine, and obviously if we examine the urine, we can find huge number of pus cells, sometimes even red blood cells can also be seen along with bacteria. This is the most common presentation that is seen especially in non-pregnant females in reproductive age group. The next kind of presentation that can be seen especially in sexually active female are acute urethral syndrome. What is acute urethral syndrome? That means the patient complains of painful micturition. That means pain only on voiding of the urine. This is basically symptoms of urethritis, and most commonly it is transmitted sexually, and you can find organisms like gonococcus that causes gonorrhea, Neisseria gonorrhoeae, chlamydia or herpes simplex virus. And in this case scenario, if we do examine the urine, we can find the bacterial colony count to be as low. The next kind of presentation that can be seen is called as the upper urinary tract infection, or more commonly called as pyelonephritis. The kind of signs and symptoms that will be seen, patient will complain of pain in the low back region, obviously where the position of the kidneys are, and on examination you can find renal angle tenderness. Furthermore, the pain could be so severe that the patient may complain of vomiting due to pain. Sometimes if there is a severe contraction of the ureter, more commonly seen in case of stone, in the ureteric stone, there might be, any idea? কিরকম পেন হবে ureteric stone হলে? First is colicky pain, second it will be radiating from loin to groin, that is along the ureter. Now how can you differentiate between colicky pain and constant pain? So colicky pain actually happens when a hollow structure is trying to compress or get rid of the stone or the calyx severely. So there will be sudden surge of pain, that is called as colicky pain. And when the spasm relieves, the pain will disappear. But if the infection is in the kidneys, that is pyelonephritis, there will be constant throbbing pain along with high grade fever. So this you have to differentiate, because pyelonephritis is obviously a very severe condition and antibiotic treatment has to be started as early as possible. Now that's all about the presentation. Now how can we confirm the diagnosis? See, I have already told you, for confirmation of diagnosis we need to have a clinical diagnosis and a laboratory confirmation of diagnosis. So if we are saying that this is an infection, that means we have to delineate what is the causative agent of the infection. So how can we delineate? Obviously the sample would very commonly be urine. How can we collect the urine? We can collect the urine by many processes. First, suppose if we are, the best example is to ask the patient to void the sample of urine. Now you see, the problem with voided sample of urine is the urine comes out through the urethra. If you recall the anatomy of the urethra, the terminal part of the urethra, what is the lining? Urethral lining the key, terminal part. That means it is similar to, কার সঙ্গে similar? Skin. So it will have organisms which are present in the skin. Now obviously the urethral opening is in the genitalia, which is very close to the anus. Hence many microorganisms in the perianal region will also be present in the periurethral region. So if we take the urine, voided urine sample, obviously it will be colonized with those microorganisms. Now those are commensals, so they are not part of the infective etiology. So this can be somehow rectified if we collect something called as midstream voided urine. So what is midstream voided urine? You ask the patient to start voiding the urine. The process of voiding should not be stopped. Only the middle part of the urine should be collected. Why? The fore part will be have organisms which colonize the urethra, and the terminal part, because the force of urination decreases during the last part, there is chances of higher contamination. Hence the mid part should be collected, and you must be able to make the patient understand that the patient should not stop voiding the urine. মানে মাঝখানে বন্ধ করলে হবে না, ঠিক আছে? Urine flow should be continuous, only the middle part has to be collected. Even about 5 ml urine is sufficient, no need to collect a full container of urine. That is the first part of, that is midstream urine. Alternatively, what we can collect, how any other way we can collect? We can go for catheterization. This catheterization can be two ways. First, suppose the patient has no need of catheterization, no medical or surgical need, okay? There might be any kind of medical or surgical need. For example, you need to monitor the urine output or many other causes. For that you need to put the catheter in situ in the patient. That means the catheter must be placed for a prolonged period of time. Most commonly done is Foley's catheter. If that kind of catheter is present, those catheters will have a sampling port. From the sampling port, you can take out the urine from the bladder with the help of a syringe. If the patient does not need continuous catheterization, you can go for straight catheterization. What is straight catheterization? You take a catheter, put it inside the bladder, take out the urine and withdraw the catheter. So these are the way we can collect the urine from the bladder. Alternatively, we can use also another method, that is called as suprapubic aspiration of the bladder. So what is this? We ask the patient to let the urine collect in the bladder. When the bladder becomes full, we can palpate in the above the pubis symphysis and introduce a needle into the bladder directly and take out urine from the bladder. Now here is the thing. In midstream urine, we are taking very cautious steps so that it is not contaminated with the commensal bacteria. But in case of suprapubic aspiration, there is no chance of contamination with commensals. So even if a single bacteria is present in suprapubic collection of urine, that is definitive indication of bladder infection. Have you understood this? Obviously, it's a invasive procedure, hence it is not done routinely. However, case to case basis can be put in. Next, in case of pyelonephritis, we can also go for something called as nephrostomy and collection of urine from the stoma. Try to understand this. Suppose pyelonephritis, that means infection is in the renal area. So in the renal angle, we can put a syringe, or we can make a stomy. That means to make a stoma means to make a hole to drain out the pus. Obviously, pus may or may not be there. Whatever collection is there, even with urine or pus, we can take it out. Now, again, in this case scenario, we have to consider it like a pus sample. So any bacterial growth will be significant in case of nephrostomy collected sample. Okay. After collection of the sample, you need to send the sample as early as possible. Why? Because urine is a very good culture media. The more you delay, more the number of bacteria in the urine sample will increase, thereby altering the report. Now coming to examination, what do we need to examine the urine? First examination is called as, we can look at it under the microscope. What we will be looking at? See, if there is inflammation, there will be signs of inflammation. The most potent signs of inflammation is appearance of pustules. What is the normal pustules in a non-infective patient? It should be less than 5 high power field. Under the microscope, you observe it under the high power of the 40x or 400 magnification. It should be less than 5, 0 to 5. That is the normal. Anything more than that is to be considered as pyuria. Pyuria means pus in urine. Now, pyuria does not mean the patient has infection. There can be many causes of pyuria. Non-infective causes can also lead to pyuria. It is only an indication of infection. Understood? Next we can see is another thing that can come out is called as red blood cells. Generally red blood cells is very less in number, 0 to 5. If it is more than that, that means RBCs are coming in the urine. Now you tell me from where the RBCs can come out in the urine. That means damage to the mucosal membrane. Most commonly, suppose in case of lower urinary tract, if the mucous membrane of the bladder is damaged, we can find RBCs. Now these RBCs may be so huge in number that the patient may complain of reddish discoloration of urine or even frank hematuria, that means blood in the urine. Sometimes it may be less in number but can be observed under the microscope. That means there might not be reddish urine, but RBCs may be huge in number under microscopy. Another method in which RBCs can be seen, if in case of upper urinary tract infection, we can even find red blood cell casts. What is a cast? Cast ki? Down. Protein. আর সেটাকে কি বলে, কি প্রোটিন থাকে? কাস্ট মানে কি? বেঞ্চ জোন প্রোটিন. What do you mean by cast? Cast দেখতে কি রকম হয়? What is the shape of cast? Tam horsefall protein. What is Tam horsefall protein? Okay. So normally in the urine you can find something called as hyaline cast. Hyaline cast are made up of the Tam horsefall protein. That is a normal finding. But in case of that, especially in case of upper urinary tract infections, pustules and RBCs may get deposited in the tubules and they may form cast-like structures. These are called as the RBC cast or WBC cast. So, presence of RBC or WBC cast will indicate infection in the upper urinary tract, whereas mere presence of small number of RBCs or pus will indicate lower urinary tract infections. Next, we can do two kind of tests, something called as leukocyte esterase test. What is leukocyte esterase test? This is detection of esterase in leukocyte, that is the pus cells. It's an indirect evidence of presence of pus cells. Next is nitrate test. This test is also very commonly done. Most of the infections, especially in young females, is caused by E. coli, gram-negative bacilli called E. coli. These E. coli, they can reduce nitrates to nitrites. So, in the urine sample of these patients, if we look for nitrites, it may come positive. So, with this simple test, we can detect UTI, that is a lower UTI, easily. How? If it is caused by E. coli, the pH will be low, then pus cells will be present, RBCs may or may not be present, leukocyte esterase test will be positive, and especially in case of lactose fermenting like E. coli, even nitrate reduction test may be positive. We can also go for gram staining, but more importantly, we have to send the urine for culture. In routine microbiological lab, we can go for either culture on both McConkey and blood agar, or alternatively we can use clade agar, that is cysteine lactose electrolyte deficient agar. Now, in case of a particular set of population, that is ambulatory females in reproductive age group. Remember these words. Ambulatory means a person who can move around by own self. Reproductive age group means about 15 to 45 years of age in females. In these females, the chances of contamination are highest. Hence, in these female patients, if the number of bacteria in a midstream collected urine sample is more than 10 to the power 5 colony forming units, then only it is considered significant. Have you understood? In all other patients, this number is not significant. For example, if the patient is a child of 5 years, be it a male or female, any number can be significant. If the patient has an anatomical obstruction in the urinary tract, any number is significant. If the patient has undergone any kind of urological surgery, any number may be significant. If the patient is an old age patient, any number may be significant. If the patient is non-ambulatory, bedridden because of any other cause, then also it will not be significant. So when you see the culture report and people almost gets fixated on this concept of significant bacteria, remember significant bacteria is only for ambulatory females of reproductive age group in case of midstream voided urine. So this is called as the CAS concept of significant bacteria. Okay. Now, very commonly we can find these organisms. How can we identify? Suppose it's a causative agent is an E. coli. We have been all taught about it. You could differentiate from E. coli. It will give a pink colored colonies on McConkey agar because it's a lactose fermenting. And how can you differentiate it from Klebsiella pneumoniae? By biochemical tests and from motility. Klebsiella will be non-motile, E. coli will be motile, and Klebsiella will have no give positive for urease production and citrate utilization, which will be negative in case of E. coli. Now, in case of Proteus, it's a non-lactose fermenting. That means it will not give a pink color colonies. Rather, it will give a translucent type of colonies, and it will have swarming on blood agar. Among the gram positives, we can have Enterococcus. It was earlier classified in the Streptococci group. Now it is reclassified as Enterococcus. On McConkey, it will give a magenta colored colonies, and it's a gram positive cocci in short chains. Among the gram positive cocci in clusters, we have Staphylococcus aureus and Staphylococcus saprophyticus. Staphylococcus aureus, like all other infections, can cause severe UTI, but in case of saprophyticus, it can also cause infections, especially in pregnant women, and may lead to consequence of chorioamnitis. Now, when we were looking at the diarrheogenic infections, we have already told you some group of E. coli causes diarrhea. Those are called as diarrheogenic E. coli. Similarly, not all E. coli can cause urinary tract infections. These are called as uropathogenic E. coli. Not only it must have some of the virulence factors like cytotoxin hemolysis, but a very important factor is called as the fimbria, that is the P. fimbria. What is the function of this P. fimbria? It allows ascending infection from urethra against the flow of urine. Normally the urine flows from kidney to bladder and from bladder through urethra to the outside. So if an organism has to cause infection in the bladder or even the kidneys and it is acquired through ascending route, it has to go against the natural flow of the urine. So it needs some very specific adhesives. Those adhesions are provided by fimbria. In case of E. coli, it is called as P. fimbria. So if an E. coli has a P. fimbria, it can cause ascending infection. Hence, lower urinary tract infections are more commonly seen with E. coli having P. fimbria. Similarly, something called as capsular K antigen. This helps in descending infection, that is from kidneys to below. So how can a descending infection occur? Ascending infection তো বোঝা গেল, ইউরেথ্রা দিয়ে গেল আস্তে আস্তে উঠলো, ডিসেন্ডিং কীভাবে হতে পারে? হ্যাঁ, hematogenous, from blood to the kidney and then it travels down. So that is called as the hematogenous route of transmission. This is the reason why in any patient suspected of having sepsis, you should be very, very careful. Urosepsis may present from UTI to sepsis or from sepsis to UTI. বোঝা গেছে? যদি লোয়ার ইউরিনারি ট্র্যাক্ট ইনফেকশন অ্যাসেন্ড করতে করতে কিডনি অবধি গিয়ে তারপর সেপসিস হতে পারে। সিমিলারলি আফটার সেপসিস urinary tract infection may also be seen. So this in toto is called as urosepsis. Okay. The other organism, Klebsiella pneumoniae, Enterobacter, Cytobacter, Protei. Among Protei family, we have three important organisms: Proteus, Morganella, and Providentia. Now, Proteus, there are two important species, Mirabilis and vulgaris, because they raise the pH of the urine. They actually helps in more predisposition to formation of bladder stones or even stones in the renal pelvis, because the pH is raised as it produces urease enzyme. Okay. Now this is the picture of Enterococcus. You can see gram-positive cocci. Okay. Now coming to viral infections of urinary tract infections, most of the infections are caused by bacteria that we can see, but sometimes virus infection can also be seen. An important noted agent is called as BK virus, named after the initials of the patient. It causes nephropathy in renal transplant recipient. That means in transplanted kidneys, these infections are more commonly seen. Alternatively, in the community, we can find adenovirus cystitis leading to hemorrhagic cystitis, that is hematuria. Among the parasitic infections, we can have urinary schistosomiasis, where Schistosoma hematobium, the adult worm survives in the vesicular venous plexus, may lead to acute or chronic schistosomiasis. This is the egg of the schistosomia. You can find this spiculated spine on the egg. What actually happens is that the adult worm lives in the vesicular venous plexus, and when it lays the eggs, it comes from the venous plexus into the bladder mucosa, penetrates the bladder mucosa, and then discharges the egg in the bladder walls. And from there, when the patient urinates, the eggs of the schistosomia is expelled into the environment. But every time the adult worm actually penetrates the bladder mucosa, it causes irritation with bleeding manifestations. Repeated and severe infection may even lead to bladder carcinoma. Okay. Among the fungal infections, the most notable infection that we can find is caused by an yeast-like fungi called Candida. So this Candida infection is very common. even in the community and also especially in the hospital, and is a very important cause of hospital or healthcare associated infection of the urinary tract. A very important feature that you must understand, presence of candida in the urinary tract is very significant, because from the bladder it can cause infections up to pyelonephritis very rapidly, and these infections are more commonly associated with immune compromised patient and also even in neutropenic patients. So if the patient is admitted in the hospital and is receiving steroids for about 3 to 5 days, then this patient can also get candida infection in the urinary tract. So this was in a gist urinary tract infections. So let me recapitulate for you. Urinary tract infection we can divide into 3 types: upper urinary tract, lower urinary tract infections, and healthcare associated or infection, that is catheter associated UTI. Now, urinary tract infections, based on the signs and symptoms, we can differentiate between upper and lower. Lower urinary tract infections will predominantly have urgency, frequency, and dysuria. That is the most common complaint. In case of upper urinary tract infections, the main complaint will be low back pain, maybe constant throbbing pain or colicky pain if ureters are affected, may be associated with nausea and vomiting, and many a times lead to sepsis. Now, one important differentiating feature that you must understand, that is in case of catheter associated UTI, if the patient is having lower urinary infections, there will be no symptoms of dysuria, urgency or hesitancy. Can you explain why? So classically, in case of lower urinary tract, we say the patient will complain of dysuria, urgency and frequency. But if the patient has catheter in situ, they will not complain of this. Any idea why? Because the catheter is already in place. Whatever urine is collected will be drained out from the catheter, so the bladder will not collect the urine. So there will be no lower abdominal pain, no urgency, and obviously because the patient is not voiding, there will be no dysuria. So this is not the symptoms of catheter associated UTI. We will cover it when we will talk about healthcare associated infections. Now let us move on to STI or sexually transmitted infections. Now, what is reproductive tract infections and what is sexually transmitted infections? Are they same or are they different? Reproductive tract infections are same as sexually transmitted infections or not? Yes or no? Let us take 2 examples. One is HIV. HIV can transmit through sexual route, so it's a sexually transmitted infection. It can also cause genital ulcers, so it is also a reproductive tract infection. Now hepatitis B, it can also transmit it sexually. It's a sexually transmitted infection. Does it cause any lesion in the reproductive tract? Is it a RTI? No. So there lies the difference. Not all diseases are transmitted sexually, and not all sexually transmitted diseases are reproductive tract infections. Understood? For example, endometrial tuberculosis is a form of extrapulmonary tuberculosis, where the inner lining of the uterine wall is affected. So this is a reproductive tract infection. However, is it a sexually transmitted disease? No, it's an extrapulmonary disease. So that is the main difference. So reproductive tract infection is a broad term that includes both sexually transmitted infections as well as other infections of the reproductive tract that may not be transmitted through sexual intercourse. In women, reproductive tract infections include infections of outer genitalia, vagina, cervix, uterus, fallopian tubes and ovaries. That is whole of the reproductive tract. In case of men, it involves penis, testis, scrotum and including prostate. Okay. So prostatitis is a reproductive tract infection, but prostatitis is not a sexual tract infection. Okay. Now coming to what are STD or sexually transmitted diseases. This means these are diseases in which the causative organism is passed from one person to the other through sexual contact. That means the diseases whose mode of transmission is sexual route. Okay. Nowadays, this terminology should be used, that is sexually transmitted infections, not diseases. Okay. Now look at this picture. STIs, RTIs. Now can you differentiate? এই ভেন ডায়াগ্রামটা দেখো, যদি পিএসএম পড়ে থাকো ভেন ডায়াগ্রামটা দেখে থাকবে। ফর এক্সাম্পল, disruption of vaginal flora, that is called bacterial vaginosis. This is transmitted, that's a reproductive tract infection, but is not a sexually transmitted disease, right? Look at the, for example, hepatitis B, it's a sexually transmitted disease, but there are no reproductive infections. Okay. Now why this is important? This is the, look at this picture. Suppose there are 100 women who have any sort of reproductive infections. Among them, only 50% will be symptomatic. Half are asymptomatic. They will harbor the disease. Among the symptomatic patient, only about 35 to 40% will actually seek treatment. Among the people who actually seek treatment, will actually follow the advice correctly, only about 10% will actually get treated properly. So now you can see till the last, where the partner, if the woman comes to the clinic, has a infection, patient was advised for treatment, she completes the treatment. But almost 99% of the cases, the partner does not take the treatment. So the infection lingers on. So this is why it is important. Now why STIs should be managed? We'll learn the sexually transmitted infections in a way that is called as syndromic management of STIs. Why this syndromic management has to be done? Because you see, the biggest challenge in case of sexually transmitted disease is the apprehension, anxiety and social stigma. So very rarely the patient will come to the doctor, and even if he or she comes to the doctor, very unlikely, even if you advise some kind of testing, that they will go through the testing process because of the stigma. So this is why it is important. You must be able to diagnose early to prevent complication. You must educate the patient about the disease so that the disease spread can be halted. Now coming to the types of infections, the first type is called as syphilis. Syphilis is a disease that is transmitted by it's a spirochete called as Treponema pallidum. Next type of disease can be seen, that is called as gonorrhea, caused by Neisseria gonorrhea. Next, chlamydia infection, that is caused by chlamydia. Trichomonas infection is caused by a parasite, Trichomonas vaginalis. Chancroid. See, syphilis, in syphilis we have a primary lesion, it is called as chancre. In chancroid, we also will have a lesion almost similar to that of chancre, but it is not caused by syphilis. Hence, it is called as chancroid. This is caused by a bacteria called as Haemophilus. Again, it is a sexually transmitted disease. Next, we can find herpes infection, most commonly genital herpes. Then another viral agent, that is called as warts. These warts are very commonly caused by human papilloma viruses. Okay. Last but not the least, but very important, is called as the HIV infection. Whenever there is a sexual disease, the mucous membranes are exposed. Hence, chances of transmission of HIV increases. Similar to HIV, hepatitis B and C infection can also increase. Donovanosis is caused by Calymatobacterium lymphogranuloma venerum caused and molluscum contagiosum. Two ectoparasitic disease can also be seen. These ectoparasitic disease include genital scabies and pubic lice, or sometimes also called as crab lice. Okay. So these are the diseases which are included in the sexually transmitted infections. So in men, what will be the manifestation? The manifestations would include urethral discharge, that is abnormal discharge per urethra, or a genital ulcer, genital itching, pain or swelling in the testis. In case of females, the most common complication is an abnormal vaginal discharge, as may be associated with genital itching. Sometimes abnormal or heavy pervaginal bleeding can be seen, or pain during intercourse or bleeding after intercourse may be seen. Other important feature may be seen is called as a lower abdominal pain and dyspareunia. Dyspareunia means pain during sexual intercourse. Some of the common manifestation obviously seen, any kind of genital ulcers may be seen, or dysuria or urethritis. Signs of urethritis may be seen. Now, how to approach in the syndromic approach? This is according to the national guidelines that you have to approach. So, under this approach, we will treat the patients based on the syndrome, because we can definitely ask the patient to go for a laboratory diagnosis to confirm the etiological agent. But because, now suppose if a patient comes to me and I think this patient could be having chancroid or Haemophilus infection. Now I ask the patient to get tested. Most of the time what will happen, the patient will not come back. Neither he or she will get tested, or neither he or she will come back to me. What I did lose is an opportunity to treat the patient. Now suppose if the patient does come back, I can have the opportunity to get the patient tested and also treat the partner. But in the first meeting itself, if I ask or press the patient to get tested, most of the time the patient will not come back. Hence it is advocated that whenever you do get a patient, examine the patient thoroughly, note down the symptoms and the signs the patient is showing, put it in the syndrome, treat it like a syndrome, then advise for testing and follow up with treatment with the patient partner. So this is how we will approach. So what could be the group of syndromes? The first kind of syndrome is called as urethral discharge. Now urethral discharge may be in case of male or female. In case of females it will be vaginal discharge. Other main manifestation is genital ulcers. Next is something called as inguinal bubos. Bubo means, any idea what is a bubo? Bubo means swelling. Inguinal bubo means swelling of the inguinal lymph nodes. Next, lower abdominal pain, acute scrotal pain or scrotal swelling, and genital skin conditions. So these are the 7 kind of manifestations with which a patient may present to you. Based on that, you must have to classify. Now let us look at the common etiological agents where it can be seen. First is vaginal or urethral discharge. If the patient comes with either of these to complain, what you can suspect of? The first suspect is obviously gonorrhea, as the name suggests, that is discharge, or in case of females it could be trichomoniasis, which leads to vaginal discharge, or chlamydia infection. Again, in case of females, along with vaginitis, we can have vaginosis. This is different from vaginitis. Vaginitis means inflammation, whereas vaginosis means there is no inflammation. It is just the alteration of the flora of the vagina. Because of the alteration, there is alteration of the pH, which leads to discharge. And it could be candidiasis. Now, in case of vaginal candidiasis, again, because alteration of the pH of the vaginal flora, there might be overgrowth of candida leading to discharge. Okay. Now, suppose the patient complains of genital ulcer and or without bubos, that means swelling in the inguinal region. What could be your differential diagnosis? First is, it could be a chancre or chancroid, that means either syphilis or Haemophilus infection. Next would be lymphogranuloma venereum caused by Chlamydia trachomatis. Other could be donovanosis caused by Calumetobacterium granulomatis or genital herpes. These are the causes of inguinal bubo, that is swelling in the inguinal region with or without genital ulcer. If the patient complains of lower abdominal pain, the most common suspicion you have to keep in mind is called as pelvic inflammatory disease, that is inflammatory disease in the pelvic region, most commonly caused by, you see, Neisseria gonorrhoeae and anaerobic bacteria. If the patient complains of pain and swelling in the testis, obviously it indicates of either epididymitis or orchitis. In that case scenario, obviously Neisseria and chlamydia may present. Itchy lesions or small swellings in the genital region may indicate warts caused by human papillomavirus or molluscum contagiosum caused by pox virus. Ectoparasitic infection may be seen in case of pediculosis pubis, pityriasis pubis. This is called as pubic lice. Body lice infection হয় ঠিক সেরকম, only in the pubic hair this lice may be seen, or even scabies may be transmitted caused by Sarcoptes scabi. Okay. Now why you should treat? You must understand about the complications of sexually transmitted infections. See, neglected pelvic inflammatory disease may end up in infertility in the patient or ectopic pregnancies. Most common cause of ectopic pregnancy is বলতে পারবে PID. Why? Fertilization কোথায় হয়? Implantation কোথায় হয়? Uterus. So after fertilization, the fertilized ovum must reach the uterine lining. এটা কিভাবে যায়? By the movement in the fallopian tube. So any kind of inflammatory disease may lead to scarring of the inner lining of the fallopian tubes, resulting in hampering of the movement of the fertilized ovum. তাহলে কি হবে? Implantation কোথায় হবে? Fallopian tube এ হবে. Now fallopian tube obviously can't expand, but if the zygote expand, it may rupture the fallopian tube, leading to a medical emergency called as ectopic pregnancy. Similarly, if the inflammatory process keeps on going, it may lead to neoplastic changes, most commonly seen in the cervical region. Okay. These are the set of questions that have been given in the national guidelines. Obviously, it includes all the signs and symptoms that I have already told you. You have to ask each and everything. Suppose the patient complains of vaginal discharge. Patient may not complain of lower abdominal pain, or suppose the patient may not complain of dyspareunia, that is pain during sexual intercourse. This you have to ask the patient. Obviously, the patient is not going to tell you everything. Next, you have to assess the risk behavior of the patient and also risk behavior of the partner of the patient. And important is sexual history, history of STI. If history of STI is present, whether it was treated or not, and finally if the patient has any kind of injection drug abuse, because that will increase the chances of other infections including HIV. So this all has to be assessed. Next, what kind of examination you need to do? First is you have to examine the patient generally, then you have to give a thorough sexual examination. What is sexual examination? You have to inspect the external genitalia, look for example in warts, or in case of molluscum contagiosum there will be small lesions, or maybe in case of say pubic lice or scabies there will be very tiny lesions. So you have to be very diligent and look for those. Then you have to perform examination, both genital examination and abdominal examination. abdominal examination should always be done in female patients. Patient may not complain of lower abdominal pain or dyspareunia, but you have to perform abdominal examination. And furthermore, in case of females, you have to do an inspection of the female genital tract with a speculum and bimanual examination. Now, these are the 6 C's that you have to do. First is you have to counsel and educate the patient about sexually transmitted infections, how to prevent them. Then you have to do contact tracing. That means you have to also reach out to the partner of the patient. Obviously, you have to promote barrier methods of contraception, convince the patient to complete the treatment. Interruption of the treatment will lead to lapsing of the disease. To come back for the follow-up and to ensure the patient and the patient's partner is being cured. বোঝা গেছে কী কী করতে হবে? পেশেন্টকে পুরো ট্রিট করতে হবে, মাঝখানে ইন্টারাপ্ট করলে হবে না, ব্যারিয়ার মেথড প্রমোট করতে হবে, ট্রিটমেন্টে কমপ্লায়েন্স থাকতে হবে, ফলো আপ করতে হবে এবং পার্টনারকে ট্রেস করে পার্টনারকেও ট্রিট করতে হবে। যারা এই 6 পয়েন্টসের মধ্যে। Okay. Now, this is the basic understanding of the syndromic approach. Normally, in all other infections, we go for the etiological approach. Etiological approach means patient present with signs and symptoms. We think of a particular infection, take the patient some clinical samples, look for the etiological agent, get it confirmed, and then treat. I have already told you why that is difficult in case of sexually transmitted disease. Hence, the syndromic approach has to be done. Now, just pictorial representation, urethral discharge in males, কি suspect করবে? Gonorrhea, chlamydia বা trichomoniasis. These are the causative agent. History নেবে, examination করবে. If possible, send for laboratory investigation. What kind of laboratory investigation you may send? In case of gonorrhea, you can send the pus for microscopy and culture. Gonorrhea culture is very difficult, not done in most of the labs, but you can send for microscopic examination. Microscopic examination কি পাবে? Neisseria is gram-negative diplococci. In case of chlamydia, obviously you have to go for the molecular test, which is not available commonly. What treatment is given? Look over here. Cefixime, it's a cephalosporin, 400 milligram should be given once daily. Then azithromycin as a single dose. দুটোই কিন্তু একবারই দেওয়া হচ্ছে, তার মানে পেশেন্ট যখন আসবে তখনই দিতে হবে আন্ডার সুপারভিশন। Then advise the patient to come after 7 days. The patient may also complain of scrotal swelling. Suspicion কি হবে? gonorrhea বা chlamydia. তাহলে কি কি করতে হবে? হিস্ট্রি নিতে হবে, এক্সামিনেশন করতে হবে। Again, send the sample, same sample. Treatment কি হবে? Same, cefixime and azithromycin. Next, inguinal bubo. If you look over here, there is a discrete swelling in the left inguinal region. This is called as inguinal bubo. Suspicion কি হবে? Chancroid or Haemophilus and chlamydia or donovanosis. Okay. In this case, patient has to be given doxycycline for 21 days. তার মানে from the start of the treatment, the patient has to take 2 doses of doxycycline 100 milligram for 21 days. So you have to counsel the patient to continue taking the dose. Okay. Obviously, partner treatment করতে হবে. Now coming to genital ulcers. Genital ulcer, commonly we have 3 types. One is called as obviously the syphilis, chancroid and genital herpes. Now how can we differentiate? First, look over here. In case of syphilis, there will be a denuded ulcer. Denuded মানে উপরে সারফেসটা নেই, open raw ulcer. But in case of syphilis, it will be painless. In chancroid, again it will be a raw ulcer, but it will be highly painful. In case of herpes, it will be very small ulcer and it will be painful. So if there is painless ulcer, think of syphilis. If it is a painful large open ulcer, then think of chancroid. If it is a small ulcer but very painful, think of herpes. Now coming to treatment. Treatment কি হবে? For syphilis, we need to give penicillin or penicillin group of drug that is sufficient for chancroid, and in case of herpes, you need to give acyclovir for treatment. Now, if the female patient comes with vaginal discharge, what could be the causes? Main is vaginitis. Most common cause of vaginitis will be either bacterial or trichomonas. Trichomonas is the protozoa. Then herpetic infection in the cervix, and finally so কি হচ্ছে, নিসেরিয়া হচ্ছে, gonorrhea, chlamydia, trichomonas or herpes simplex. In case of candida vaginitis, vaginal discharge may be seen, সেখানে antifungal দিতে হবে. I will come to this treatment. Next comes lower abdominal pain. Lower abdominal pain including dyspareunia যদি complain করে, you can think of gonorrhea or chlamydia and anaerobic infection in the pelvis. আচ্ছা, এখানে একটা জিনিস বলে দিই, sometimes the patient may present with non-genital manifestations also. Oral or anal STI may also present. ঠিক আছে? So similarly, you can even find ulcerative lesions in the mouth or in the anus also. As a human papilloma virus causes warts, you can see various manifestations of what from vulval to penile ulcer. This is a manifestation of molluscum contagiosum. You can see a small umbilicated মানে এটা একটা ডিম্পলিং থাকে like lesion, and this is highly contagious. If the patient scratches this lesion and scratch another part of the body, a new lesion will appear in that site also. Hence it is highly contagious. Okay. Now this is called as crab lice. There are two type of lice infection in the body. কি কি হতে পারে? একটা মাথায় হতে পারে, সেটাকে কি বলে? হেড লাইস। আরে উকুন, সব হাঁ করে থাকে, উকুন বোঝো না? আর কোথায় হতে পারে? আর একটা হচ্ছে বডি লাইস হতে পারে, প্রেজেন্ট অন দ্য বডি. So body lice is very commonly seen in homeless people and in mentally unstable patients. The lice does not reside on the body. ঠিক আছে? If you are suspecting body lice infection, even if you examine the whole patient thoroughly, you will not find a single. It is present on the clothes. But in case of pubic lice, the lice actually latches onto the pubic hair, much like hair lice, and it is transmitted obviously during sexual intercourse, body to body contact. Next comes scabies. Scabies again is an ectoparasitic infection. It commonly affects the children and sometimes even elderly. Very commonly manifestations can be seen on the hands and foot. Sometimes it may also be present in the genital region, especially when a huge part of the body is affected. So in this picture you can see scabies lesion on the scrotum of this patient. Okay. Now coming to the final part. The government of India has made possible with the help of this national guideline, in which they have made treatment pouches. And specific drugs are kept in specific packets for specific syndrome-like management. So these are the color-coded patches. Let us look one by one. First is urethral discharge. Urethral discharge hole ki bhabbo? Ar chlamydia are. So this contains cefixime and azithromycin as a single dose tablet. So if the patient complains of urethral discharge, you hand out this grey colored kit. This is also called as kit 1. মনে থাকবে? মনে obviously থাকবে না, পড়তে হবে বারবার. Okay. If the female patient comes with cervical discharge, same etiology, same kit. This has to be administered right then, right there. Testing পরে, আগে you have to start the treatment. Next part is in males the same disease can cause swelling in the testis and epididymis, leading to painful scrotal swelling. তাহলে urethral discharge in male or female, vaginal discharge in female, and painful scrotal swelling in male. You have to give the grey colored kit or kit number 1. It has cefixime 400 milligram single tablet and azithromycin 1 gram single tablet. Both has to be taken under supervision right then, right there. Next, if the patient comes with vaginal discharge, not from cervix but from vagina, then you must think of vaginitis. So what are the possible causes of vaginitis? Commonly trichomonas and candida. তাহলে কি আছে দেখো, seclinidazole, metronidazole, tinidazole, seclinidazole. So it is effective against anaerobic and even in case of trichomonas. So to treat trichomonas you have to give seclinidazole 2 gram single tablet stat. Stat মানে right then right there. And in case of fungal, that is vaginal fungal infection, most commonly is candida. So for candida we have to give fluconazole 150 milligram stat. So in case of vaginal discharge you have to give the kit number 2 or green colored kit. Next comes genital ulcer non-herpetic. Non-herpetic কি কি হতে পারে, কি বলেছিলাম? শ্যাঙ্কার, শ্যাঙ্ক্রয়েড, হার্পিস, এই তো তিনটে। হার্পেটিক লেশন কি হলো, খুব ছোটো ছোটো হয়, রেডিশ কালার, হাইলি পেনফুল। শ্যাঙ্কার বা শ্যাঙ্ক্রয়েড হলে লার্জ আলসার, ওপেন। শ্যাঙ্কার হলে পেনলেস, শ্যাঙ্ক্রয়েড হলে পেনফুল। নন হার্পেটিক মিন্স ইদার শ্যাঙ্কার বা শ্যাঙ্ক্রয়েড। তার জন্য আমরা কি দিচ্ছি? বেনজাথিন পেনিসিলিন, দ্যাট ইজ দ্য ড্রাগ অফ চয়েস ইন কেস অফ সিফিলিস। তাহলে শ্যাঙ্কার থাকলে আমাকে পেনিসিলিন দিতে হবে। অ্যান্ড অ্যাজিথ্রোমাইসিন, দ্যাট ইজ দ্য ড্রাগ অফ চয়েস ইন কেস অফ হিমোফিলাস অফ শ্যাঙ্ক্রয়েড। বোঝা গেছে? তাহলে শ্যাঙ্কার বা শ্যাঙ্ক্রয়েড থাকলে কী দিতে হবে? পেনিসিলিন অ্যান্ড অ্যাজিথ্রোমাইসিন। সামটাইমস দ্য পেশেন্ট মে বি অ্যালার্জিক টু পেনিসিলিন। আই থিঙ্ক ইউ হ্যাভ হার্ড অ্যাবাউট পেনিসিলিন অ্যালার্জি। তাহলে পেনিসিলিন দেওয়ার আগে পেশেন্টকে জিজ্ঞেস করতে হবে পেনিসিলিন অ্যালার্জি আছে কি। ইফ দ্য পেশেন্ট সেজ ইয়েস ইউ কান্ট গিভ পেনিসিলিন, তখন যেটা আমরা দিই সেটা হচ্ছে এই কিটটা, যেটা ডক্সিসাইক্লিন আছে। উই রিপ্লেস পেনিসিলিন উইথ ডক্সিসাইক্লিন, বাট ড্রাগ অফ চয়েস ইজ পেনিসিলিন। ঠিক আছে? সো দিস ইজ genital ulcer non-herpetic. Now if the patient has small painful herpes lesion, you have to give anti-herpetic drug. The most common drug is acyclovir. You have to give 400 milligram TDS for 7 days. Obviously এটার নাম হচ্ছে kit number 5 or red color. Next, if the patient complains of lower abdominal pain or dyspareunia or lower abdominal tenderness on examination or pain during bimanual examination. Bimanual examination means cervical tenderness. এগুলো যদি থাকে তখন আমরা দিচ্ছি মোস্ট কমনলি কী করে, গোনোরিয়া, ক্লামাইডিয়া, অ্যানারোবস। তাহলে কী কী দিচ্ছে দেখো, অ্যানারোবসের জন্য মেট্রোনিডাজোল, গোনোরিয়ার জন্য সেফিক্সিম, আর এইটার জন্য হচ্ছে ডক্সিসাইক্লিন। Only difference is cefixime is single drug OD stat, metronidazole twice daily for 14 days, doxycycline twice daily for 14 days. So this has to be continued for 2 weeks. So you have to make the patient understand why full treatment is necessary. Last but not the least, if the patient complains of inguinal bubo. Inguinal bubo means scrotal swelling in the inguinal region. কি কি হতে পারে, কি কি করে? ভুলে গেছো? শ্যাঙ্ক্রয়েড, তাহলে azithromycin and doxycycline, but here doxycycline is for 21 days. Color of the kit is black. ঠিক আছে? এইটাই, this is the most important part. এইটা জাস্ট একবার রিক্যাপিচুলেট করছি। Discharge, urethral discharge, cervical discharge or painful scrotal swelling. Target হচ্ছে gonorrhea, chlamydia. Kit grey color, kit number 1 grey color. কি থাকে azithromycin cefixime. Next, vaginal discharge. Vaginal discharge মানে altered secretion commonly caused by trichomonas and candida, seclinidazole and fluconazole. Color of the kit is green. Kit number 2. Genital ulcer may be herpetic, non-herpetic. Non-herpetic হলে syphilis বা chancroid. সেখানে হচ্ছে কি পেনিসিলিন প্লাস অ্যাজিথ্রোমাইসিন, পেনিসিলিন অ্যালার্জি থাকলে রিপ্লেস উইথ ডক্সিসাইক্লিন। সেটা হচ্ছে ব্লু কিট, এটা ব্লু কিট। আর নন হারপেটিক আলসারের জন্য হচ্ছে হোয়াইট, যেটা উইথ পেনিসিলিন। পেনিসিলিন রিপ্লেস হলে ব্লু কিট। হারপেটিক আলসার হলে রেড কালার। লোয়ার অ্যাবডোমিনাল পেন ইয়েলো কালার, আর ইঙ্গুইনাল বিউবো ব্ল্যাক কালার। ঠিক আছে, ওকে। নেক্সট ইম্পর্টেন্ট পয়েন্টস কি শুধু খাইয়ে দিলে হবে না, you have to educate the patient about the disease, how it spreads, how you can prevent, advise sexual abstinence during the treatment, otherwise there will be treatment failure, convince the partner to get treated. Next, follow up the patients. Suppose 21 days বা 14 days of the antibiotic দিচ্ছ, you have to follow up the patient at 3rd, 7th, 14th and 21 days for lower abdominal pain. কেন? নট অল লোয়ার অ্যাবডোমিনাল পেন আর STI, অন্য কজও হতে পারে। তুমি শুধু অ্যান্টিবায়োটিক লিখে ছেড়ে দিলে তাহলে যাও 14 দিন পরে আসবে, ইট মে বি এ সার্জিক্যাল এমার্জেন্সি, পরে আসতে পারে। সো ইউ শুড অলওয়েজ কাউন্সেল দ্য পেশেন্ট টু ফলো আপ অন দ্য 3rd ডে। কী দেখবে? পেশেন্টের সাইন্স অ্যান্ড সিমটমস কমেছে। ইফ ইউর ডায়াগনোসিস ইজ কারেক্ট, মোস্ট অফ দ্য টাইম দ্য পেশেন্ট উইল গেট বেটার, সাইন্স অ্যান্ড সিমটমস ভালো হয়ে যাবে। যদি ভালো না হয়, ইফ দ্য অ্যাবডোমিনাল পেন পারসিস্ট, you have to refer to a higher center or to either a gynecologist or a surgeon. Okay. So this is about STI. Each and individual disease discuss korini, but what I have discussed is how to approach a patient as a whole. Go back, read about the common STIs including syphilis, chancroid, genital ulcer disease and other sexually transmitted infections.